Hello everybody, my name is Llewelyn, and today I'm going to be presenting on a model of trauma therapy I've been working on for several years. It's called Developmental Reenactment Trauma Therapy. It's probably been a little less than a week that I did a presentation on this at the Salt Palace in Salt Lake City, Utah. And after that presentation I got asked by a handful of people if there was any further information. My manuscript is, sitting actually just right here. But I haven't finished the work on it. I've just been really busy building my private practice and everything. So obviously it's not ready for people to read who are interested. So I figured I'd go ahead and toss some videos on my website that'll help train a little bit more on this model. And a couple of things you need to know though. I always tell people there's nothing new under the sun, and that's the case here with this model of developmental reenactment trauma therapy. Simply all it is, and I'll explain how it came about, but really it's just a reanalysis of how to utilize psychodynamic and attachment theory in a specific trauma model therapy that was developed by Judith Herman, Luxembourg, van der Kolk, and a number of other well-respected researchers. So with that said, why don't we go ahead and jump into the model itself. Actually, before we do that, I should not assume that everyone is familiar with the concept of complex post-traumatic stress disorder, also called type 2 PTSD. So with that said, I'd like to encourage you to go over to the Trauma Center's website, which is through Harvard University. Bessel van der Kolk runs that website. He's the lead over there at the Trauma Center. On that website there's several outstanding articles, access to a number of resources that I've pulled in developing this model, and I highly encourage you to do so. As I go through some of these slides, there will be some web addresses for that very website. And then also quite important is Judith Herman's book. This is the new edition that came out in 2015. Yeah, I think the original came out in 1992, 94, somewhere around there. Highly recommended it. Much of my work is based upon Judith Herman's work as well, and also incorporating Nancy McWilliams' psychoanalytic work, which I'll introduce to you later. So with that said, what is this concept of complex PTSD or type 2 PTSD? I like to use the word type 2 PTSD. The idea of having a complex and a simple form of PTSD just doesn't bode well or sit well with me, especially when I look to someone and say, well, you got the simple form. Well, it's not simple. So what is this idea? First of all, in the DSM-4, it was included in the associated features. We are now on the DSM-5, and the DSM-5 committee has actually incorporated some of the symptoms of type 2 PTSD into the diagnosis of PTSD as it is in the DSM-5. So this is somewhat of a moot point, but here are the original diagnostic criteria. It's drawn from researchers like van der Kolk, Judith Herman, and so forth. As you can see, with type 2 PTSD, there's a long history of repeated traumas that occur. So if you think of domestic abuse, child abuse, living in a war-torn country, anything that has a long history of repeated abuses can cause type 2 PTSD to set in. If you notice here on this side right here, it says personality alteration. Bessel van der Kolk and a number of other researchers have basically suggested it, and I concur that the outcome of type 2 PTSD really is an alteration in how a person's personality functions in the world. It's an alteration to their overall personality, and we'll get to that shortly. So with the repeated trauma, there's also what's called affective dysregulation. Now, affect is simply the external expression of emotion. What it's speaking about here, though, is really emotional dysregulation, or the observable dysregulation that tends to occur. So under the idea of affective dysregulation, you can have a number of things such as a difficulty in modulating anger, frustration, sadness, and that can lead to self-destructive behaviors, cutting, engagement in sexual activity that is self-destructive. It can also lead to suicidal preoccupation, a desire not to live. That also leads again to the cutting, the self-mutilation. There's also problems in modulating sexual activity, which I noted before. there's people who have been traumatized sexually that completely just subdue or repress any sexual desires, and there's others that will actually act that out as if it's a way of coping, it's a way of being, it's a way of understanding, so they become hypersexual. And then there's also excessive risk-taking that can occur, and the affective dysregulation. In regards to affective dysregulation, there's been research that compared inpatient or females who were in inpatient psychiatric care and diagnosed with borderline personality disorder, and they took those females and compared the diagnostic criteria for type 2 PTSD and said, hey, we really do have a strong correlation. And they actually found that of those women in the high 90s, high 90% of them had actually gone through repeated trauma and met the diagnostic criteria for type 2 PTSD. Some researchers have suggested borderline personality disorder and type 2 PTSD are one and the same. That's still up in the air, and there's a lot more research that needs to be done in that area. Regardless, I think it's a lesson in terms of how we look at individuals with borderline personality disorder, because that disorder, the diagnosis, comes with a pretty substantial stigma where the diagnosis of complex or type 2 PTSD doesn't have that same type of stigma. So that's affective dysregulation. Let's take a look at the next one, which is alterations in consciousness and somatic flashbacks. This is alterations in consciousness is basically speaking about dissociation. And if you look at dissociation, there's a continuum, anywhere from a basic dissociation, which everybody experiences, which would be daydreaming, to a more intense dissociation like actual multiple personality disorder or dissociative identity disorder. What's common with dissociation is something called derealization and depersonalization. Derealization is a condition where it feels as if things are not real. It's almost as if the client is looking at a movie. And that happens around the time of the trauma as well as afterwards. And then with depersonalization, they don't feel like themselves any longer. They feel like they're either outside of their body, they feel as if they're watching themselves function, and they have little control over it. So that's derealization and depersonalization. Next level dissociation, we start to actually get into, in a sense, checking out or spacing out for extended periods of time. That's leading to alterations in the person's ability to remember things. And when we get into this and we actually start talking about dissociative identity and more dissociative features, we'll cover this dimension characteristic in greater depth. Now, somatic flashbacks, this is one of the signs that I have found is very telling of type 2 PTSD. Somatic flashback, as Bessel van der Kolk spoke, is basically the body remembers the trauma. It is a flashback, it's a body memory is what it's basically speaking about. I recall back to a group I was running with women who all met the diagnostic criteria for type 2 PTSD. We were in the second stage of treatment, which we'll get into in another video. But the second stage of treatment has the individual doing a narrative of the trauma. And it's very intense, and because we try to get people to do it in a first person, engaging all the senses as they retell the story. Well, this woman was about to say, and that's when he hit me. And I looked up, and some of the group members looked up, and this woman's face, the right side of her face, had basically flushed completely red. The other side was a little sweaty, but definitely a different hue. I mean, didn't have the same blood rush as the right side of the face did. And right as I noticed that, she said that she was hit in the face with a baseball bat, and she pointed to her right side. So what was happening at that point, her body was actually physically re-experiencing that event where she was hit. And because that was happening, the blood rushed to that portion of the face as if it was happening at that moment. So that's an example of a somatic flashback. The next three actually is kind of social features that go along with this. One of the things that I found particularly impactful for the individual and what developmental reenactment trauma therapy focuses on is the alterations in the perceptions of self, the offender, and others. The alterations in the perceptions of self include a feeling of ineffectiveness, almost as if they're stigmatized. They don't feel that they can accomplish anything in life. They feel pretty much abandoned, neglected. It includes a sense of feeling permanently damaged, guilt and responsibility. I'm sure many of you have heard of that trauma guilt that tends to go along with this. Well, there's a sense of guilt and a sense of responsibility when we get into the essential features of DRTT, which is Developmental Reenactment Trauma Therapy. I'm going to speak about the power of responsibility and helplessness. So keep that in mind as we go through that. There's also a belief that nobody could possibly understand what they're going through. And then finally, there's a minimization. They tend to rationalize or minimize the overall impact of the trauma. The alterations in perceptions of the offender or the trauma. Many of you have heard of Stockholm Syndrome. Same type of idea. There tends to be almost an idealization with the person, the offender, or the abuser in the situation. The idealization of them and devaluing of other people, especially themselves, the individual who's going through this. And then there tends to be a rationalizing of the actions that are occurring with the abuser, kind of explaining it away. As you can imagine, in this type of a situation with child abuse or domestic abuse, trust of others is significantly damaged. And it's almost an inability to trust others, which develops. As a therapist, that's very unique, which is one of the first crises we'll get into. And there's also research shows that if you've gone through a single trauma, you're more likely to go through a second trauma and a third trauma and so forth. That's really evident with interpersonal trauma or trauma between two individuals. And finally, there's the alterations in systems of meaning. This is basically your belief system drastically changes. In a later slide, I'll be talking about some research by Robert Epstein and Janoff Bullman. They did 2 studies 5 years apart, and it shows the cognitions, the beliefs that 2 people tend to have before a trauma and how those are altered after a trauma. So with that, I highly encourage you to pick up work by Van der Kolk, Luxembourg, Judith Herman, and do a little bit more research on type 2 PTSD. So where did this idea start from, this developmental reenactment trauma therapy, which I'm going to start referring to as DRTT? I was sitting there, and I was actually sitting in session with this woman who I've been working with for quite a while, and she leaned forward, kind of somber, having a bad day, and she said to me, you know, I never learned to trust my mother. I thought that was insightful. In fact, it was profound at the time. And then in the back of my head, I started to realize, well, how did she even learn to trust a guy like me, a therapist, a male, that she has to sit in a room by herself and share some of the most vulnerable and intimate secrets of her life? How did she ever get to that point of trust with me? And about the same time, I was reading through Judith Herman's book, and this page number on the slide is incorrect. It's page 133 in the earliest edition. I was reading this, and this quote that I have up on the slide by Judith Herman, and it says, as you can read, recovery can take place only within the context of relationships. It cannot occur in isolation. In her renewed connections with other people, the survivor recreates the psychological faculties that were damaged or deformed by the traumatic experience. These faculties include the basic capacities for trust, autonomy, initiative, competence, identity, and intimacy. It occurred to me that, especially in that section that's noted red, the trust, autonomy, initiative, competence, identity, and intimacy, I mean, that should sound very familiar for therapists, because those are the Ericksonian stages, at least the first 6, with the trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, competence is the outcome of developing industry, and then identity versus identity diffusion, and intimacy versus isolation. I thought I'd come across something really cool, but along with this process, I noticed that she had a footnote in her text, and that footnote led directly to a comment saying, well, these are obviously Ericksonian stages. So I didn't come up with anything new, but it led me to think. And in that thought process, I realized that in this work in trauma, we're actually recreating, as she notes here, the survivor recreates those stages and recreating trust, autonomy, and initiative, I realized that through therapy we were creating corrective therapeutic experiences that would allow for those stages to be gone through and hopefully corrected, at least between the therapist and the client. Now, before we move forward, as I was doing my study, in Judith Herman's book and in others who write on this topic, they speak about 3 phases of trauma therapy for people with type 2 PTSD. The 3 phases include stabilization, remembrance and mourning, and reconnection. Well, as I was reading through stabilization, I noticed that it covered 6 topics: education, self-care, self-soothing, but then I noticed the next 3 were trust, safety, and boundaries. In my head, I realized, well, trust versus mistrust. Safety has to also do with trust. It also has to do with boundaries. And I also note that boundaries are an outcome of developing autonomy, which is Erickson's second stage. And then I realized before the individual can move into the more intense trauma work of re-experiencing and doing the exposure therapy, they have to have a sense of mastery, a sense of accomplishment, and sense that they can do this. And that actually develops in the next series of Ericksonian stages, which is initiative versus guilt. They have to have the initiative, the belief that they can, the industry, and the ability to accomplish this. And then obviously with identity, they need to be working on identity. And then intimacy creates a connector between the exposure therapy and the remembrance and mourning section and the reconnection section, which is the final section. So with that, I noticed that the Ericksonian stages actually fit really well into the 3-tiered model of trauma therapy. As you can see, trust versus mistrust, autonomy versus shame and doubt fall within the first. Initiative versus guilt, as the client is developing that initiative, the belief that they can accomplish this. As I noticed that that's actually a cusp to suggest that maybe they're ready to move forward into the second stage, which is the remembrance and mourning and the exposure therapy. And at which point they continue to work on their initiative, their industry, identity, and then intimacy. When they start working on the intimacy or the reconnection with people, that is a sign that they're getting ready to move on to the reconnection stage. And from reconnection onward to giving to others and feeling competent about what they've done and looking back on it with some integrity, rounds out the Ericksonian stages. So that's how DRTT came about. Now, I just happen to be Freudian. I work a lot from the psychodynamic perspective, from some analytic perspectives, and from attachment perspectives. It was through this that I looked back and said, well, how are these being reenacted specifically between the client and myself? And those are the aspects that create this corrective therapeutic experience we're going to get into shortly. Now, before we do that, it's time to introduce some of the basics of DRTT. So in this model, I've developed 5 principles of DRTT. Number 1 is that Erickson, in his 8 stages of development, or 9 stages of development actually, but in those stages of development, as we go through them from beginning of life to the end of life. And that's kind of this big overall macro view of the developmental stages. I believe that when we get into any relationship, whether it's between the client and the therapist, or between the client and another person in their life, they start working through those same stages again on a micro level. In other words, they meet someone, they have to figure out, do I trust this person, or should I not trust this person? Now, of course, as with previous relationships, it kind of helps define that. If they've gone through a number of relationships that are very untrustworthy, they'll probably start a little bit more towards, I need to distrust this person. It's going to take a lot more work to bring about trust. But they will still, with that individual, work through the trust versus mistrust stage. Once they accomplish that, that's when they start to move into autonomy versus shame and doubt. In other words, can I be myself within this relationship and have some control over myself within this relationship, or do I become passive and submissive and do what the other person wants me to? Once they figure that out, and that they can become autonomous, then they start figuring out the initiative and the industry. This is really what is their role within the relationship. and so on and so forth, their identity within the relationship, and then obviously the intimacy and so forth. It kind of gets a little weird at that point. But so the first principle is that within this model, within the relationship with the therapist and the client, there will be a micro unfolding of the psychosocial stages. We need to be very aware of what's going on there. Number two, that Erikson's psychosocial unfolding or unfolds within the three-tiered model, which I pointed out in this slide. It unfolds quite nicely. And I just missed my slide. There we go. Number three, reenactments occur through psychodynamic and attachment means. And I'm speaking about transference, countertransference, transference neuroses, projective identifications, adaptive functioning, all sorts of different processes that will happen between the client and the therapist that will reenact this. And it's the role of the therapist to understand that this is a reenactment and how to flip that to create a way for healing. Again, that's considered the corrective therapeutic experience. The next is that reenactments can lead to the corrective therapeutic experience and prepare the client for work in the next stage. So a corrective therapeutic experience is simply when you experience something in therapy that challenges a previously held belief. So previously held beliefs such as relationships are terrifying and dangerous, or that people are out to hurt you, or that you're not a good person, that you need to be submissive in relationships. All sorts of different beliefs are held by the individual, the client, that will be reenacted in the therapy. Now, if we can correct some of those negatively impact some of those beliefs that negatively impact the client, we then create a corrective therapeutic experience that hopefully they'll draw into the next situation when that occurs, and it'll be rewritten in a sense. And then finally, number 5, identifying the corrective ratio leads to better understanding of the transference. So if you notice Erikson, and come back to this slide right here, Erikson wrote his developmental stages in ratios. For example, trust versus mistrust. It's a ratio. We actually need to have resources in both. We need to have resources in trust, and we need to be able to have resources in mistrust, because there are people we just should not trust. We have to be discerning. Now, one should be stronger than the other. Typically, we want the syntonic condition, typically the first portion of the developmental stage, trust, autonomy, and initiative, and so forth. We want that to be stronger. But I've met people that are far too trusting, and they get victimized repeatedly. In that situation, the corrective ratio would be, okay, well, we need to work a little bit on the mistrust part of this. Or instead of mistrust, I like to refer to it as the discerning abilities of the individual. Now, I've also met people who have autonomy or control, and some people who have way too much of it, and they lack a lot of shame, guilt, and doubt. You think about the sociopath or someone like that, and I think, well, it's probably a good idea that we actually try to help this individual experience a little bit of shame and guilt. And so I try to work on that feature. But typically, in general, I'm trying to build the syntonic feature, which is the first part. So I want to help them develop autonomy, but I first always need to analyze which portion of the ratio I need to work within, because that's going to impact how the client responds to me and how I respond to the client. And when I'm talking about how the client responds to me, that's considered the transference in psychoanalysis, right? So the ratio that needs to be worked on will define the transference in a sense. We need to be able to read that and understand that. Now, before we move forward, I have these principles that I just went through, but then there are also some really essential aspects of developmental reenactment trauma therapy. There's also one here. So these are the essentials. I think these are real obvious. Number 1, we are working with people and not a diagnosis, a disorder, or a condition. We are working with people. We're not trying to treat them. They're not treatable using a workbook. They're people. And we need to understand that, because it's only in that ability to engage in the relationship that this is going to help, as Herman said in that first quote. in the context of relationships. So that is extremely important. Now, in DRTT, we're trying to reenact some of these developmental stages. Just because we are trying to reenact early childhood development does not mean we treat the client as a child. And that'll become clear as we start getting into these stages. We do not treat the client like a child. And we'll talk about transference, in which that may be part of the process, but we don't do it in a way that infantilizes them. We'll come back to that later. Now, symptoms and behaviors often have a purpose and meaning, which is very important for them to understand, especially within the education section of the stabilization phase. And finally, very common in trauma work, the adage, the slower you go, the faster you get there. Okay? The slower you go, the faster you get there. I know there are times when it feels like I'm not doing anything in therapy, or I think the client has to think, man, what is going on here? What am I paying this guy for? When really we're doing all this underlying work, such as the transference work and the testing and so forth, that really goes unnoticed oftentimes by the client. And they're, I get insecure to think that a client thinks that. So there's a push that I'll go through. It's like, oh, I got to make it look like we're doing something that they're expecting, maybe some exposure therapy. And just because I'm feeling that way, if I were to jump into this other portion of therapy that's just not appropriate at the time, I'm going to actually cause greater damage. So the slower you go, the faster you get there. I do have some precautions here with DRTT. Number one, in trauma, there's often something called the law of silence, especially if it's been interpersonal trauma. Think about anyone who's gone through domestic abuse, child abuse, ritual abuse, anything like that. I don't think I've ever met a person who had an abuser that said, I want you to go openly tell everybody all the bad things I've done to you. It just doesn't happen that way. What tends to happen is the abuser says, you tell anyone and I'm going to hurt you and your family. I'm going to make life miserable or anything like that. So the client is actually sworn to silence. They've been sworn to silence throughout their life. And then they come to this guy, a therapist, or this woman, their therapist, who says, tell me everything. In other words, the therapeutic relationship is violating just inherently this law of silence, which is very dangerous for many traumatized clients. So we need to be very cautious and know how to work with that. Now, the other caution is jumping into the deep end, as I was mentioning before. Number one, you just don't do it. The slower you go, the faster you get there. There's also a tendency to interpret too deep. Some people have been victimized, many people have been victimized at such an interpersonal level that a therapist who can kind of understand what's going on and will interpret some of the emotions that they're not yet willing to face, that can feel really violating because I'm reading something about them that they're not yet willing to accept. So you got to be careful with that. And the power of the transference, or how the client responds to me as the therapist, is extremely important for this process, and we need to understand the different ways a client will react to a therapist. And we're going to go into that in greater detail, so I'm going to just leave that there for right now. Early on in my career, I realized that with type 2 PTSD, there's often that alteration in the person's personality and their identity. When I would say, well, I think I know what's going on, I think it could be type 2 PTSD, it would give them individuals like, oh, okay, so I have PTSD, and they would start to identify. And because they had such a sparsity of kind of their own identity, that became their identity. And when that became their identity, it became very difficult to let that go and replace it with something else. So a lot of people had adopted that identity. I learned very quickly that people experience PTSD, and they are not PTSD, which goes back to my essential that we're treating people and not a diagnosis or a disorder. The other thing that'll help with this in terms of the adoption of identity is if you look at every single symptom of PTSD, you can identify that it was an adaptive coping strategy during one of the most darkest moments in their life. It is a very creative, adaptive way of coping. Now, an adaptive way of coping does not sound like a disorder. It only becomes a disorder, quote unquote, when they're in a different situation that doesn't require that type of coping, but the coping continues. So in other words, we're dealing with some of the most resilient, creative people that you would probably ever come across. It just looks bizarre if they're not in that situation. So they need to understand just how creative and resilient they are. And then finally, a lesson I've learned, and a lot of this stuff that I've learned from my clients, is taking responsibility for the trauma is oftentimes easier for them than to feel helpless that it happened to them. In other words, I was raped because I was there, or I had incited it somehow, versus saying I was completely helpless and had no control. Taking responsibility is actually accepting some level of control. I don't like to hear that, but I've realized that if I try to take away that responsibility and leave them only with the helplessness too early, it's very, very difficult, and what we get is some regression at that point. So those are the cautions. In the next video, we're going to actually start getting into some of the specific things that we need to start doing in the stabilization phase. So I thank everyone for joining me on this. Have a good night.